Very good afternoon, everyone. It's my great pleasure to invite Dr. Rathan Shetty sir to give a talk on osteoradionecrosis. Dr. Rathan Shetty sir is very close to me, and I've known him from quite a few years. Dr. Rathan Shetty is currently associate professor at Department of Head and Neck Oncology at Tata Memorial Hospital and ACTREC. So he was trained in Tata Memorial Hospital, and he has over 28 publications with a great over 380 citations. Sir, over to you.
Thanks for a generous compliment. Osteoradionecrosis is not so common of complications post radiotherapy, but it's a dreaded complication. And if you go by history, in 1922, Regard was the first person who described osteoradionecrosis. This is an old entity. It was fairly common about a couple of decades back, but due to modern radiotherapy techniques, the incidence has come down. So, what is the diagnosis? There are a lot of there are 13 different classifications, and there are various diagnostic or definitions given. Most of the definitions are based on 3 to 4 definitions given by like Marx et al. Or Van Merkelsen et al. So what is it? An exposure of an irradiated bone which fails to heal without intervention. This was the definition given by Marx in 1983. He did not talk about the duration. Chronic non-healing wound, and he did not talk about the radiology of the radiological aspect of it. Another definition was again given by Marx and Johnson. Marx and Myers also has come up with the diagnosis or definition. Chronic non-healing wound caused by hypoxia, hypocellularity, and hypovascularity of irradiated tissue. This was the most accepted definition. Bone and now we have another definition. So bone and soft tissue necrosis of 6 months duration excluding radiation-induced periodontal breakdown was a definition given by Van Merkelsen in 1995. So when can it occur? It can occur as early as around 3 months to up to 3 years. Most of the time it occurs within 3 years. But the patient who has received a radiotherapy for curative radiotherapy for head and neck cancer is susceptible for osteoradionecrosis throughout his life. And the incidence used to be around 17 to 37% in ortho voltage era, where cobalt-60 or the older radiation technology was used. Modern IMRT techniques, the incidence hovers between 2 to 10%, and generally it is less than 5%. Common in men. Why? Because men tend to have oral cancer more than women. Mandible is the most commonly affected site, and usually it is much more common in multimodality treatment. I'll also talk about the presentation elaborately in the subsequent slides. It can be asymptomatic. Sometimes there can be an exposed bone. There can be discharge, non-healing fistula, fractures, ulcers, and infections. This is the most commonly accepted definition now given by ASCO Guidelines 2024. It says osteoradionecrosis of jaw should be characterized as a radiographic lytic or mixed sclerotic lesion of bone or visibly exposed bone or bone probed through a periodontal pocket of fistula occurring within an anatomical site previously exposed to a therapeutic dose of head and neck radiation therapy. Usually the radiation dose is more than 50 grays. ASCO has come up with guidelines in 2024. Most of my talk will be based on that, and I have not put all the recommendations because the duration of talk would be very long if I complete, but most of my talk is based on ASCO Guidelines 2024. Incidence, like I mentioned, it is as low as 0.4% to up to 56% if you take the historical records. In the modern era, it is less than 5%. Oral cavity and oropharynx are the most common sites, common cancers which will have overend. Why? Because the mandible is at risk when you irradiate the organ. Higher incidence of overend when chemoradiotherapy is used. Curative versus adjunctive RT, similar risk of overend. There is no difference in overend because the dosage that is received, the organ at risk is more than 50 grays, both in curative and adjunctive. And risk of developing overend is increased in patients with poor oral health. Edentulous patients are at a lower risk of developing overend. Why? Obviously, they do not have teeth and there is a mucosa covered bone. That's why probably that is the cause. Studer reported a 1.3 incidence of 3% incidence of ORN after a parotid sparing IMRT. So IMRT techniques for parotid sparing RT tended those series had very low incidence of ORN because of the better dose at the mandible. Conformal 3D and IMRT incidence of ORN has dropped to less than 6%. So there are various theories which were given. Radiation osteitis in Ewings in 1926. Watson and Scarborough in 1938, triad of radiation, trauma, and infection was a theory which was proposed. Trauma to the soft tissue overlying bone in the oral cavity permitted bacteria to enter into the underlying demineralized bone, leading to osteomyelitis. But ORN and osteomyelitis are not synonymous. Why? Because osteomyelitis there is a periosteal inflammatory response also, whereas in ORN that is not seen. So Marx was the most commonly accepted theory for a long time, and basically it consists of hypoxia, hypocellularity, and hypovascularity, which in turn causes tissue breakdown and chronic non-healing wounds. Brass in 1990 came up with this obliteration of inferior alveolar artery theory, whereas radiation-induced obliteration of the inferior alveolar artery was dominant factor leading to ischemic necrosis of the mandible. This is the most commonly accepted theory now, the fibroatrophic theory of Andrew Lyons, given in 2008. Fibroblast populations not only undergo total cellular depletion in response to radiation exposure, but also show a reduced ability to produce and secrete collagen in the surrounding tissue. So this is the accepted theory now, the fibroatrophic theory. The risk factors. The site of the primary, oral cavity, oropharynx tend to have more. If the tumor is close to the mandibles, then the chances of ORN and the site of radiation received to the mandible is more. So the height of primary has a bearing on risk of ORN. Posterior mandible is more commonly affected area of ORN because of its compact and dense nature. Again, like I said, the site has a bearing on whether the patient is at risk for ORN. Poor oral hygiene, odontogenic infections, periodontal disease, dose of radiation received. Invariably, most of the head and neck cancers receive more than 60 grays. Use of brachytherapy, not very commonly used now, but historically, brachytherapy was something which was used significantly in treatment of oral cancer. And when the tumor was close to the mandible and brachytherapy was used, the dose received to the mandible was quite high, and this could precipitate osteoradionecrosis. Nutritional factor is also poor nutrition is also risk for ORN. Concomitant chemoradiation. If you consider only radiation versus chemoradiation across all series has shown to have higher incidence of ORN across all series. And injury to the jaw immediate in the post-radiotherapy period can precipitate ORN. So avoid doing any dental procedures at least for 6 months to a year post-radiotherapy. Advanced stage of tumor because of the extent of the radiation field can also precipitate ORN. This is a review article by Nabil et al. Which confirm whatever I have told. Advances in delivery of 3D CRT has decreased and our IMRT has decreased the incidence of ORN. Brachytherapy had one of the highest incidence of ORN. Patients receiving adjunctive radiotherapy versus curative intent did not show any difference. And in this series, chemoradiotherapy showed no increase in osteoradionecrosis as per his review, but there are series which have shown that chemoradiotherapy has increased incidence with relation to only RT. Accelerated fractionation with dose reduction is associated with reduced risk, whereas hyperfractionation shows elevated risk of developing osteoradionecrosis. So this is taken from the guideline that I mentioned. How should ORN be characterized, graded, and reported? And which patient should be considered as high risk for ORN? What is the recommended workup to characterize ORN? Classification, I have mentioned all the, this is not an exhaustive list. There are 13 different classifications for ORN. I am talking about the most popular classification systems for ORN. 1983, Maas came up with this stage 1 to 3 classification based on the response to hyperbaric oxygen therapy. We'll talk about hyperbaric oxygen therapy also. Stage 1 is 60 dives, patient heals, full mucosal coverage. The patient has responded very well to hyperbaric oxygen therapy. Stage 2 is combination of minor surgery and 60 days. Patient has responded to hyperbaric oxygen therapy, achieved full mucosal coverage. Stage 3 is any pathological fracture, orocutaneous fistula, radiographic evidence of resorption of the inferior border of the mandible. Here 30 dives plus resection. We'll talk about hyperbaric oxygen therapy later on. What was the problems with this regimen? Epstein's classification based on imaging and clinical findings. Marx did not include imaging, whereas Epstein included imaging. Stage 1 was resolved or healed ORN. Stage 2 is chronic, more than 3 months, persistent, non-progressive ORN. Stage 3 is progressive or active ORN. I'll skip Kagan and squats. Notan is the most recent, not the most recent, but one of the most recent. Again, it has been modified by some others, and it has 3 stages based on imaging and clinical findings. So always include imaging and clinical findings when you state the disease. ORN stage 1 is confined to the alveolar bone. Stage 2 is ORN limited to alveolar bone or mandibular, above the level of the mandibular canal. ORN stage 3 is extending to the mandible under the level of the mandibular canal with ORN skin fistula or pathological fracture. This is the Notanis classification showing grade 1, grade 2 and grade 3. This has been modified by the group which conducted HOPON trial, that is hyperbaric oxygen for prevention of osteoradionecrosis, where they included minor bony spicules. These are small exposed areas of bone less than 2 centimeter across, that is 20 millimeter across. So they have classified it into not ORN, that is mucosal healing, or minor bony spicules less than 2 centimeter across or less than 6 months. When it is ORN, when there is exposed bone more than 20 millimeters or that is 2 centimeter across and beyond 6 months, through the oral mucosa or facial screen, where malignancy has been excluded in any case of prior radiotherapy. So ORN is a diagnosis of exclusion. First thing you should rule out is recurrence. Don't look for ORN. You rule out recurrence if there is a persistent fistula or an exposed bone, then only you come up with a diagnosis of ORN, and you take biopsy whenever necessary. But you should have the sense when not to take biopsy. We'll discuss regarding that. So clinical presentation, persistent localized pain, patient can have. See, in early stages, there may not be mucosal changes. Only radiological changes would be there. We'll talk about the imaging findings also. There can be exposed bone, soft tissue changes like ulceration or necrosis of the tissue overlying the affected bone, infection with purulent discharge, trismus due to pain and tissue changes. Whenever a patient has trismus and has foul-smelling discharge and all that, first thing is to rule out recurrence. Second thing you should rule out is ORN. Pathological fracture due to weakened devascularized bone. Again, recurrence can cause pathological fractures. Halitosis, that is foul brand. Here I have a case where patient underwent marginal mandibulectomy with FRAF reconstruction 2 years back, received adjuvant RT because it was stage 3, and after 2 years he has developed an ulceration in the lower alveolus, still RMT bone exposure. It's a case of ORN. Biopsy did not show any malignancy, and the radiological findings are also consistent with ORN. What do you do next? How do you evaluate this case? First thing is examine clinically. Clinical intraoral examination including direct visual or endoscopic examination and formal periodontal assessment by the dentist. OPG. How good is OPG? If you want to look for ORN in OPG, there should be at least 30% bone loss. I mean, it's not a very accurate way, but for as a screening tool, you can use it. But remember, it's not very sensitive. Most of our patients will undergo cross-sectional imaging, either a CT scanner or MRI. If you are in doubt of recurrence, ask for a PET scan. We'll talk about PET scan evidence also. Bone scintigraphy, we do not use it very commonly. Biopsy, often negative, and you should take it from the most representative side. From where? That is more important. Stage the disease now based on clinical, radiological, and response to HBO. This is something controversial now, which used to be the standard of care about a decade back. Disease progression, duration of bone exposure, and treatment necessity. This is a concise review article on osteoradionecrosis. which talks about the features of ORN, not detectable radiographically in early stage and not correlated with severity. There may not be any radiological evidence of disease, but there may be mucosal exposure more than 2 centimeter across. Features, bone may be exposed. If you see all the definitions which are given, every definition talks about bone exposure. Features range from normal appearance to localized extensive osteolysis, sequestra, and can be fracture also. Definitive radiographic alterations in early disease are increased radiodensity, mixed radioopaque, radiolucent lesion, orthopentagram, I talked about it. Get a CT scan at least. Difficulties in differential diagnosis between overend and recurrent tumor is always there. MRI also shows marrow signal, cortical destruction, slight to mild irregular enhancement, advantage of excellent tissue contrast and high spatial resolution. Scintigraphy, I have not used it, so I won't talk about it. Another review article looking at differentiating, another study which is looking at differentiation from recurrent disease and CT versus PET CT imaging. Remember, a standard uptake value, there is nothing the nuclear medicine guys always say there is nothing standard about standard uptake values. So standard uptake values, there is a significant overlap between ORN and recurrence, but ORNs tend to have a lower standard uptake value compared to recurrences. The mean value is around 11.3 in recurrent cases, whereas in ORN the mean is 5.3. Then there are other radiological factors. Talk to your nuclear medicine guys, discuss with them, and then come up with the diagnosis of exclusion, that is osteoradionecrosis. Don't jump into it. Management. Before talking about management, we should know what are the preventive measures, how do you manage conservatively, and of course surgery. I won't be talking extensively about surgery because most of the surgery involves reconstruction, which will be spoken by the subsequent speakers. What are the recommended best practices for prevention of ORN of the head and neck region prior to radiation therapy? Before starting CTRT, do a thorough dental checkup, oral care. If a patient is a smoker, ask him to quit smoking and tobacco, build up his nutrition, and radiation oncologists should also think about the IMRT planning volumes for organs at risk. Preventive measures in oral cavity. Remove the infectious dental or oral foci. Wait for at least 2 weeks after you've done a dental procedure before starting radiotherapy. But of course, if you're not able to complete the treatment within the stipulated time, then you may not have 2 weeks. So that takes precedence over 2 weeks for waiting for after a dental extraction. Always tumor control over all this. Improve the diet. Teach him oral hygiene methods. Fluoride supplements can be given. Reducing the effects of xerostomy and mucositis. If patient has dentures, check for the dentures, whether it is fitting or whether it is causing mucosal trauma. You may have to adjust the dentures. And if he needs any dental procedure, try avoid extracting the teeth. Try to do endodontic treatment by preserving the teeth, doing filling or crown or whatever, which do not require dental extraction, if it is feasible, that is. And symptomatic treatment. So these are some international Society for Oral Oncology guidelines for oral care. Dental care improves overall well-being of the patient. Saline rinses can be given. Bicarbonate rinses can be given. Chlorhexidine can be given. Mouthwashes. In prevention of this one, mixed medication mouthwash anesthetic may decrease gag reflex and may lead to aspiration, so they do not recommend that. Supersaturated phosphate solution used in 2 trials, no guidelines could be formulated. What you can do is dental care, saline rinse, and bicarbonate rinses. Chlorhexidine can be given, but you have to be it cannot prevent the development of ORN. For oral hygiene, you can give. Another set of guidelines which have been again taken from the ASCO guidelines. It's copy. I can be sued for copyright violation, but I'm not taking permission. This is freely available. So we can use it for educational purposes. Summary guidelines that address symptoms and supportive care needs associated with ORN. Various suggestions for pain, dysphagia, oral care, nutritional deficiencies, dysarthria. This is available freely. You can look it up. Now coming to the treatment of ORN. As per the stage, symptoms, and previous treatments. Treat the comorbidities, maintain oral hygiene. Observation, I would see it's a small minor bony spicule, less than 2 cm, maybe a 0.5, less than a centimeter across. You can observe it. Don't do anything. Or alternatively, you can give Pentoxifylline, vitamin E, Tocopherol, and with or without chlordronate. This is a bisphosphonate called the Pentoclo regime. We'll talk about the evidence for that. ORN with discharge or fistula, pain, infection, always give this. You can combine it with antibiotics, either doxycycline or amoxiclav or whatever is the standard of care in your center, ciprofloxacin. The recommendation says that give at least a week of antibiotic post dental extraction. It can be up to 3 weeks to a month. Prior antibiotic prophylaxis before dental extraction has not shown any benefit, but you can give not more than a week before, but there is no strong evidence to recommend that. These were the recommendations stay. Now coming to HBOT, 25 to 30 dives, 2.4 absolute atmospheric pressure for 90 minutes. This is for overt ORN, not as a prophylaxis. We'll talk about that also. Surgery, yes, if there is an overt ORN refracted to medical management, you will have to do surgical treatment. So you have a case here which has an exposed bone. Does HBO therapy prevent early ORN and implant exposure? How do you manage? And role of HBO and other hypervascular agents, that is the ones which I mentioned. We'll briefly talk about hyperbaric oxygen therapy. What is a dive called? The mechanism is endothelial cell proliferation resulting in neovascularization and collagen synthesis. Basically, it involves breathing 100% oxygen through a face mask or a hood or in an enclosure like this at an atmospheric pressure of 2.4 pascals for 90 minutes. That is 80 to 90 minutes. That's called a single dive. And 5 days a week for up to 30 sessions, followed by 10 or more sessions based on the response. That was the Marks protocol based on the response to hyperbaric oxygen therapy. This is the Marks protocol. Osteoradionecrosis treatment, stage 1, 30 sessions. Bone softens, granitial tissue develops. Response at 10 more sessions if there is some exposed bone or mucosa needs to be debrided, local debridement, resolution of ORN. Does not respond, at 10 more sessions, bone and mucosa healed, resolution of ORN. If it does not heal, continuity resection, he suggests HBO session, hyperbaric oxygen session, even for stage 3. And soft tissue flap if needed, do appropriate reconstruction. This is not followed anymore. Why? Because HBO, the evidence for HBO is not very strong in ORN treatment, except for in early cases, like post-dental extraction when the dental tooth root is exposed. That is the only area where HBO is found to have benefit. Whereas in stage 3 and stage 4, Notani classification or Clinrat classification, it has not shown to have any benefit. Only for early stages you can use HBO, but HBO as a prophylactic tool has not shown any benefit across randomized controlled trials. So it is not recommended. Do not use HBO as a prophylactic tool. If you are planning a dental extraction or a dental procedure, there is no role of hyperbaric oxygen therapy as a prophylaxis. This is a randomized controlled trial ORN 96 study, which is showing that it's a multi-center study, large multi-center study, and see the number of ORN cases are very less. So the accrual of patient is also less. You won't get 200, 300 ORNs for accruing in randomized controlled trials. So in this, they did not show any benefit. There was no difference actually. So time to treatment, actually it did worse. Overt mandibular osteoradionecrosis did not benefit from HBO. So it was a 12 center study. Ambulatory patients, adults with overt osteoradionecrosis of mandible were assigned to receive 30 dives of hyperbaric oxygen therapy. as per I explained before, and study was stopped for potentially worse outcomes in HBO arm. And 68 patients were enrolled and analyzed. At 1 year, 19% had recovered in HBO arm and 32% in the placebo arm. So the HBO arm actually did worse than the placebo arm. And time to treatment failure and time to pain relief was similar between two treatment arms. So there was no difference when HBO was used in a prophylactic setting. Coming to HOPON trial, hyperbaric oxygen for prevention of osteoradionecrosis. Again similar, it's a randomized controlled trial to prevent osteoradionecrosis of the irradiated mandible after dental alveolar surgery. Phase 3 randomized controlled trial, 1:1 randomization. 30 days were used. 144 patients were randomized and 100 were available for analysis. The ORN incidence was 6.4%. Again, this trial was also stopped. And control, there was no difference actually. But across these two, the incidence of ORN was very less. And dropouts from the trial was higher in the HBO arm. Now coming to interventions of preventing osteoradionecrosis of jaw in adult receiving head and neck therapy. This has some relevance. This is a review article which looked at various studies which will prevent ORN. 4 studies identified evaluating 342 adults, all assessed as at high risk of bias. 3 broad interventions were identified: platelet-rich plasma, fluoride gel and high content fluoride toothpaste, perioperative HBO, and antibiotics. None of the studies were well designed, so no recommendations can be made regarding these. So there is no role of platelet-rich plasma, no role of fluoride. You can use it, but don't expect much benefit from it. Definitely no role for hyperbaric oxygen therapy. This was a study by Sylvie Delanian where they looked at the use of pentoxifylline and tocopherol, a phase 2 trial, 18 patients, where they gave a daily combination of pentoxifylline, which is a vasodilator, vitamin E, tocopherol is an antioxidant, for 6 to 24 months. Complete resolution in 89% of the patients. It is an effective treatment, and mucosal and bone healing occurred within a median period of 6 months. So how does it act? When you give radiation, there is destruction of the osteocytes, loss of osteoblasts, defective osteolysis, osteogenesis, radiation-induced fibrosis and atrophy. Late necrosis can occur. What does pentoxifylline do? And it is a vasodilator. Vitamin E is an antioxidant. Chlordronate is a bisphosphonate. It decreases osteoclastic bone destruction. Now coming to the studies which are showing that pentachlor regimen works. So this is a review article which shows the use of pentoxifylline. This is the standard of care now. Use pentoxifylline, tocopherol, chlordronate in early cases of ORN. So in all these studies, the number of patients are not very high. The highest was in Lance, 85, where pento regimen was used. Chlordronate was not used. And you can see that the healing was quite good. Healing in 89% in the Adanian study, 42% in McLeod study, and Robart study had 59% healing. Lions had 22% healed, stable in 48%. Very few patients progressed, actually, on 1/3 progress. Hayashi, around 84% healed, and in most of the regimens use Pento. Then there are studies which are comparing pentoxifylline to vitamin E along with chlordronate. This is a study by Lobard et al. Which used you can see the dosage where initially the patients were given tissue infiltration reduction phase where antibiotics, prednisolone were used and anti-gastric antacids were used, and then followed after 4 to 6 weeks, patients were started on pentachlor regimen where 800 mg of pentoxifylline, that is 400 mg, 2 tablets amounting to 800 mg per day, 1 gram of tocopherol, 1600 mg of chlordronate, it comes in 800 mg tablets, given 5 days a week from Monday to Friday, and prednisolone was also added 2 days a week, Saturday and Sunday. So what were the results? 16 of the 21 patients had improvement in mucosal ulceration after 3 months. 12 of the 17 patients after 6 months of pentachlor had mucosal. Healing was achieved in 16 patients and the median healing time was around 3 months. And this is a systematic review, which again shows that pentaclo regimen works. There is an ongoing randomized control trial for regarding this called Raptor study. The approval will be over in 2025. We will have further evidence regarding this. You can see in the robot trial, the success rate with only Pento was between a success rate was 16 out of 21, around 80% had success, whereas the systematic review said that it can increase up to 100% when clotronate is used, and the least you can achieve is 54.4%. This is what the systematic review by Marcelo Arquez Lemus shows, that adding clotronate definitely improves outcomes. This is the ASCO guideline that I talked about. Again, they have subdivided ORN into the partial thickness ORN and full thickness ORN. When the defined disease extent whereby removal of all, this is for with regard to surgical management. How do you manage surgically? If it is a partial thickness ORN, that is when you do a sequestrectomy or a debridement, it should not lead to oronasal defect or oroantral defect or lead to pathological fracture. Full thickness is when you do this, if it leads to potential pathological fracture or oronasal or oroantral defect, it's called a full thickness ORN. This is a typical finding. I think almost all of us have come across this. Patient is tumor control is quite good. Surgery was done a year back, underwent free fibula reconstruction, received adjuvant CTRT, now has come with bone exposure and exposed bone here, and exposed the teeth, exposed the jaw. In the first, you can see the fibula bone is exposed here, and here the plate has been exposed. So reconstructive challenge. There is no role of any conservative management in this case. Do surgery. Much worse case, stage 3 ORN. You can see the mandibular bone is exposed. This patient underwent marginal mandibulectomy. Now he has a pathological fracture, and there's not much of a tumor here. This is not a tumor. This is osteoradionecrosis. So it's most of the osteoradionecrosis ends up like this. Patient have a discharging sinus, exposed bone, not much of inflammatory response from the tissue. To come to partial thickness ORN, you can still do minor procedures like debridement, sequestrectomy, alveolectomy, soft tissue flap closure. Most of the defects should be less than 2.5 centimeter. You can use localized flaps for vascular cover. But if it is a full thickness ORN, if it involves the mandible, do a segmental resection. Maximallectomy defects, you need to do myocutaneous flaps or osteomyocutaneous flaps based on the size of the defect. Advantage it allows is you can also do dental implantation in these patients because these are cancer survivors, but they have problems due to ORN. Obturation can also be used. Obturator can also be used if the patients are poor candidate for microvascular surgery. But I would recommend doing a vascular flap. Why? Because these don't tend to heal so well. So you have to cut the bone till you get bleeding margins. So let's try to do a vascular flap. The recommendation for obturation is only when if any medical condition precludes microvascular surgery. Try to do a segmental for fibula reconstruction for any segmental defects, and myocutaneous flaps only in selective settings where medical status is compromising prolonged duration of surgery. Always free flaps are recommended over pedicle flaps. Of course, the free flaps will be spoken by subsequent speakers. So the goal is to resect bone till you get bleeding margins. Re-establish the continuity of the bone is a challenge due to proximity of oral contaminants, state of the adjacent tissues, stress-bearing requirements of a functional mandible. So any time these will end up with free flaps only. To summarize, medical treatments only for all patients needing extraction. 1 week before date of planned extraction and subsequently 1 to 3 weeks post surgery. Antibiotics with pentaclo regimen. You can combine with some minor surgery in stage 2, doing an oral sequestrectomy with pentaclo regimen, and wait for the response to treatment. But if it's a major ORN, there is no role of medical management. So take home message is identify the problem, assessment of severity, prevent always dental prophylaxis. In a high volume setting, this may be difficult, but send all the patients for dental prophylaxis who are being sent for adjuvant or definitive radiotherapy. Respect tolerance doses. This is for the optimized doses to the organs and risk. This is usually during RT planning, and detect early and during regular follow-up, that is once every 2 to 3 months. Look for complications. Unless you look for complications, you tend to miss this, and they will end up with much more severe complications than what you could have avoided. Thank you. I'll take questions.
Thank you very much, sir, for putting across such a difficult topic in a very concise manner. We can have any questions for sir.
Sir, Mike.
Hi, Dr. Rathan, thanks for the talk. My
Sound.
hello. Yeah. My question is, some patients, as you said, there will be a subclinical OR.
Yes.
Like you will identify them only during
Clinical examination. May not be radiological evidence also.
no, patients who doesn't have any clinical signs, but they have radiological evidence of ORN. Right? You have taken OPG or CBCT for some other reason, but then you find sclerotic bone with a lot of changes, but they will be asymptomatic completely. So now, to treat this, first of all, whether to treat these patients or just observe them, or so now how you treat these patients with this Pentoxifylline regimen, how long we want to treat these patients?
Usually there is the recommendation, they say, see, you can actually observe these early cases who are not symptomatic. I have put it in the slide also, you can observe. But Pentoxifylline has shown to have very good results. You can perfectly.
How long?
6 months. They say about 3 months to 6 months. You can in prophylactic setting around 4 to 6 weeks. In treatment setting around 6 months. You can go up to the trial which used Pentoxifylline regimen was designed for up to a year. For 6 months, so you can use
what are we
that.
Seeing as the endpoint?
So usually you see the patient every 3 months.
Like, are we seeing a radiological reversal of the condition?
You won't see a radiological. It will not worsen. You cannot expect radiological
we are
reversal.
expecting a static situation throughout. So if we see after 6 months it is static, then let us.
You can stop this. See, I don't have much experience using Pentoxifylline because we don't see ORN as often as what we used to see long back. But we have used this Pentoxifylline regimen very recently, and the patient had an exposed bone. Used Pentoxifylline regimen, actually it healed well. And the patient had improvement in symptoms also.
So basically, we almost follow the same protocol. When to stop becomes a big question.
When to stop? Yes, that is a question. I would say.
Keep giving.
But wait for 6 months. Wait for 6 months. If there is no deterioration, I think you can manage conservatively.
Because we are definitely not going to see a reversal of the.
No, that you will never see. A dead bone can never come back to life.
So we don't know when now to let us stop this. That question never comes up.
Don't pull the tooth out.
No, even after
HPOT, regarding HPOT, the only indication of HPOT is exposed, that is like some similar to a tri-socket. That has shown to have benefit, but other than that, HPOT has not shown much benefit in treatment of ORN, especially for stage 2 or 3, which was advocated by Marx. But stage 1, yes, definitely there is evidence for that.
I think even Dr. Robert Marx now feels that HPOT was a hyper kind of thing.
Yes.
Even he is not recommending it.
No, nobody recommends HPOT. I think it is something which is no longer in vogue. And have a low threshold for surgery if it is a stage 3 ORN. There is no point in waiting. We have had patients who were treated medically for 6 months to a year, and patient had very poor quality of life. Halitosis and inability to eat through the mouth is a bad way to live. Better off he do some surgery. Yes. And do a vascularized flap reconstruction. I would say avoid PMMC. PMMC only when you are not able to reconstruct the jaw because of medical causes and all that. Very procedural defect. Then you can use, but use free flaps. which is a challenge in a post-irradiated setting.
That's a great presentation. One clinical tip, you said identify osteonecrosis before subjecting the patient to HBO therapy, if at all. So in case you have a recurrence and you don't identify and you subject the patient to
HBO, yes.
You're aggravating the whole
Yes.
problem. You have to be very careful.
That's most important thing is ORN is a diagnosis of exclusion. You should not diagnose ORN over recurrence. Even if you add on recurrence, that is still all right. Yes.
Thing is, even if you plan surgery, considering that this patient has ORN, you've taken biopsy, it is negative, when you're operating, go in thinking that there is malignancy.
Yes, the case that I described had early oral cancer. We waited for a year, he had early oral cancer. It was stage 1 cancer, but still there was malignancy there, which probably developed in a field of fibrotic area.
So what I'm trying to say is, whatever, I've operated very less on patients who had ORN, we have tried to manage them conservatively as much as possible. But in the small numbers that we have operated, more often than not, they had malignancy in that. So take margins, don't just remove the bone.
Always treat it like a malignancy, because in the end you need to have bleeding edges. So whatever the radiographic changes are there, take a centimeter of margin all around, you will get bleeding edges and you are sure that you are away from the lesion that you are addressing. Even if it is malignancy, you are sure that you have taken care of it. And one important intraoperative tip, do not strip the periosteum unnecessarily. Because especially when you do a marginal mandibulectomy, do not strip the periosteum unnecessarily. One of the case that I showed, I remember one of our residents stripped the periosteum completely, did a primary closure. It was not even a local flap. In patient received adjuvant RT and all that, and then he developed ORN. Probably there is no strong evidence to back this up. This is what I feel, that the mandibular blood supply is dual blood supply, endosteal and periosteal. When periosteal is also taken out, then the chances are high. Any more questions? We see very less of ORN nowadays. Most of the series is less than 5%. And the series which involves parotid sparing IMRT, it is reported to be about 1.6% only. So for every 100 cases, you only see 1 or 2 patients. Thank you.